while we're getting our other guests into the room, I would like to first thank Itzik Ben Israel again and the management of the conference. And I'm happy to introduce, standing beside me, Dr. Anthony Bleetman. Anthony is a consultant in emergency medicine, as well as an honorary associate professor of medicine. Served as an air ambulance doctor in the UK, becoming a clinical director for HEMS in the Midlands. He currently serves as an advisor to the Ministry of Defense in the UK on matters dealing with less lethal weaponry. And experienced WannaCry at first hand, didn't you?
Thank you.
Thank you.
Whoever wrote my bio missed out some important parts from the bit that I sent them, which is essentially I'm an emergency physician. I know nothing about cybersecurity, nothing. But I had the pleasure of addressing a cybersecurity conference, which is great. In terms of my background, I can do that in a bit more detail. That's where I started out. I still have that car and it's working fine. But I was brought up in North London and I went to a school and the level of anti-Semitism there turned me into a Zionist, which was easy. So at the age of 17, I came here and I completed my medical studies 200 meters from here at the medical school in Tel Aviv University. And at the when I finished my army service, I went back to the UK for a number of personal reasons, and I had a rather nice career in the UK as an emergency physician, as a pre-hospital doctor, and various other endeavours. A few years ago, things in my personal life had changed, and I had a desire to come back to Israel, and I now have an interesting lifestyle where I work 50% post as an emergency physician at Beilinson Hospital here in Petach Tikva, and the rest of the time I work freelance in the UK as an emergency physician. So I was checking my airline points last night. I don't quite have enough of first class to America, but I'm getting there. So every month for the last 3 years, I've been working in both countries. So on the 12th of May 2017, I just happened to be working in a small hospital called Newham Hospital in East London, and my shift started at 12 o'clock. And when I got to work at 12 o'clock, I went to the consultant, the senior doctor's office, and there was people were making a lot of noise. Their computer screens had gone blank, and messages had come up demanding a ransom for their computers to be switched on again. And it became apparent within probably about 15-20 minutes that there was a very significant cyber attack on the way. We switched on the news and we learned that various hospitals around the country had been affected by seemingly the same malware that had been distributed. We now know that it took out around the world 230,000 computers in 150 countries, and it was ransomware. And it only affected those with no Microsoft security updates. And guess what? The NHS saved some money by not updating their protection systems, and a lot of them got taken out by something that was entirely preventable. Okay. That works.
כן, אולי נשאיר לי. Ladies and gentlemen, we already started the session. I asked Dr. Bleetman to hold on for 1 second to let you all in. So Dr. Bleetman on stage and has already started talking, reached the WannaCry crisis. That's the on our conference.
Yes, so just a quick recap. It's lovely to see the audience quadruple in size. That's great. So I think for the 75%, I'll give you a very brief introduction. My name's Tony Bleetman. I was born and brought up in London. I studied medicine in Tel Aviv, and I had a career in the UK, and now I'm an emergency physician working in both countries. I hold a part-time post at Beilinson Hospital, and I work as a freelance consultant in emergency medicine in London, and I fly backwards and forwards every month. So I also told at the start of my presentation, I know absolutely nothing about cybersecurity, but I do know a little bit about managing an emergency department. And over the next 10 to 15 minutes, I will describe our experience of continuing to provide emergency medical care when there is a cyber attack underway. So what we do know is that what I know was that on the 12th of May 2017, I went to work for a 12 o'clock shift as one of 3 senior doctors in a modest, medium-sized emergency department in East London, and all the computers went down at the same time, and messages came up demanding money in exchange for putting the information back on. And what we learned subsequently that about 250,000 computers across the globe were affected. And this was ransomware, and it only affected those computers that hadn't had the latest Microsoft security updates, and a lot of the NHS had not invested in the latest security update, and so a lot of the NHS was affected by this malware. It affected about 30% of hospitals, 603 primary care organisations, and it turned out later, I had no idea about this, that this was not the first attack on the National Health Service in the UK. Big picture stuff, operations and appointments were cancelled. 5 hospitals got very, very worried by what was going on and closed their doors to ambulances. That's a controversial decision, but local decision makers decided that they were not safe enough to accept emergency ambulance work. We know that no patient data was stolen, and on the first day, a kill switch was identified. It took a while to circulate the kill switch around the organization, which had to be individually loaded on each computer in the hospital. I learned that subsequently. It's not something that could be done centrally. So it took a while to get the system back on, and then there were some issues of confidence, shall we say, in the fix that had been put on the computer. So this is a map showing the widespread effects of this ransomware attack across the United Kingdom. And there's a list of affected health organisations or groups of hospitals called trusts, and at the time, and I still work at Barts Health, which has a number of hospitals in the east of London. So, to understand the effect of this sort of malware on a health service, one has to explain that in the UK there is a centralisation of specialist services. In this country, every hospital will deal with trauma, every hospital will take heart attacks, and every hospital will take strokes. That's how it works. In the UK, the thinking is that you need specialist centres which will deal with specialist time-critical conditions, round the clock, led by senior clinicians. And so in the last decade or so, we have witnessed centralisation of major services. So to understand the effect of malware on a health system, one needs to understand the local operating environment within the UK. So this is a map of London, and in London there are 4 major trauma centres. for each quadrant of London. Those trauma centres will accept patients from their sector of London, but also extending beyond London out to the home counties. And you can see there, for instance, on the top left of the screen, that outside of London, the St Mary's Hospital will accept from Stevenage, Luton and Dunstable and Watford, towns outside of London. The rationale is that if you invest an extra 10-15 minutes in patient transport time to a centre that specialises in major trauma all the time, your results will be better, and they indeed are very much better, and that applies to strokes and for heart attacks. So one of the first things that happened was that the local trauma centre said, sorry, we're not taking major trauma because our surgeons cannot see CT scans, and if they can't see CT scans, they're not confident in operating. So we lost the trauma centre, which was interesting. So now we have to receive the odd trauma patient in a hospital that is largely de-skilled in managing major trauma, because major trauma has not been going there for about 7 or 8 years. So that was the first issue. Briefly, and I say briefly, the stroke centres, or HASUs, hyperacute stroke units, of which there are a small number in London, closed their doors to strokes, and heart attack centres for angioplasties closed their doors briefly, very briefly. And so the instruction was, the thinking was, if we can't send stroke patients and heart attack patients to specialist centres, then we're going to wind back the clock and treat them as we used to in the old days before specialist centres. For those patients who are appropriate, we can offer thrombolysis, and turning the clock back in terms of what we can offer. So that was what was happening regionally: loss of trauma, loss of stroke and loss of heart attack. And for the first day we had to deal with that locally. Fortunately, no major trauma patients arrived. There was one patient that probably needed PCI who was managed locally and who was managed with old treatment protocols, who subsequently got transferred a couple of days later. So within the hospital department, this is in the east of London, immediately we've lost patient registration. We don't know where patients are because our computer system that tells us where patients are is not working. We don't know where patients are. We don't know at what stage of their treatment they are at. We've lost the ability to see radiology images on computers. There's no PACS. Labs. We can't get lab results, all the bloods that have been sent to the labs. We can't book appointments for patients that we've discharged. We cannot produce discharge letters for family doctors. And for a short time, we have to take the responsibility of managing heart attacks, strokes and trauma in a hospital that is largely de-skilled in these clinical areas. So what does that look like, and how do we solve the problem? Well, there was medicine before computers, and we are very dependent on computers now, but having experienced clinicians with a bit of seniority who remember how to write on paper, who remember how to do things with a little bit of clinical instinct and clinical acumen, is a good thing. So what did we do? And as I said before, I'm no expert on cybersecurity, and I was not the alpha clinician. I was not running the department. I was one of 3 seniors on that day. What did we do? Well, the alpha clinician got out a whiteboard and drew a map of the department with each cubicle. And he stood there with the senior nurse, and we very quickly transferred the patient's location onto a manual whiteboard. And then it was decided that each patient on that whiteboard would have a nominated doctor and a nominated nurse in the department, and the whiteboard would be the centre of activity for the entire department. And staff were called for a briefing. In the middle of the department, a message was given out to patients in the hospital and patients in the waiting room what was going on. And we came up with a plan that was modified as required. And what that means was this. Clearly, we've lost patient registration, so paper registration is relatively straightforward. Pre-prepared patient records. They were ready for major incidents anyway, so we used those. we very much operated on an area basis within the department. I was given an area to manage, perhaps 8 patient cubicles with 2 or 3 junior doctors, and their job was to liaise with me, for me to help them make clinical decisions, and feed back to the whiteboard at the centre, advising on progress. We had to modify some elements of clinical practice. Access to X-rays was very limited. We could see X-rays, but we had to either use a portable machine, because that's a standalone item of equipment, we can see it on the monitor, or we could go to the X-ray room where the X-ray was taken and see it on the monitor there. It wouldn't go on PACS, but we could go and see X-rays there. So we tried to minimize the use of radiology and rely on old-fashioned clinical acumen and a little bit of experience and judgment. And we, in cases where we would normally have perhaps reduced a fracture, we would splint the fracture in plaster, send the patient home with an appointment to come back in 2 days' time, where we could look at it again and reconsider the decision. So we dropped perhaps our level of medical care while this was going on in real time. So it's essentially first aid fracture management. We had to be very selective with our imaging. CTs was perhaps the biggest problem. The CT machine was working. The CT machine was not connected to the hospital computer system because of the malware attack, but it was still working as a standalone unit. The CT scanner in the hospital that I was working had a hard drive on which it could store a limited number of images, and I believe, I could be wrong on this, I've got a number of 120 in my head that we were told at the time, probably 120 scans. I think that hard drive could hold, I could be wrong. And so any requests for CT scans had to be carefully considered and restricted so that we would not exceed the daily limit that the hard drive allowed us to do on the CT scanner, and they put a radiologist at the CT scanner who could give us advice in real time. So that was radiology sorted, that's fracture management sorted. Major trauma didn't come in, fortunately, to a hospital that was de-skilled in major trauma. Someone that should have had angioplasty didn't get it for a while, but was maintained on medical management. In terms of labs, the lab machines were functioning. They were producing results, but they were producing paper results. They were not being fed onto a computer system because the computer system wasn't working. And so the decision was taken that one junior doctor would go to the labs every half an hour, pick up the papers with the lab results, come back to the whiteboard, see which doctor was responsible for which patient, and would distribute the lab results. And it's a system that did not pose a major problem. That worked quite nicely. And the other thing, of course, is we didn't know how long this was going to go on for. The initial fear was that it would go on for days, if not longer. Watching news reports on the TV was not helpful. It just fueled anxiety. So the decision was made, keep staff on site, and if you're going to keep staff on site, be nice to them, give them rest periods, and make sure there's boxes of pizzas being delivered at regular intervals. So that was in real time, and this went away. The problem in real time went away within a couple of days, and the system recovered. The aftermath, which is something that perhaps planners of today and tomorrow need to consider, is if you've been using temporizing measures for a day or two, there's now perhaps 300 or 400 patient records just from the emergency department in a 24-hour period that need somehow to be put back onto the system once the system's up and running. And this was done in an old-fashioned way. We got paid money to come in and sit. We all got a large box of patient files, and we sat and we typed them into the system to bring them up to date. Not much fun, and that took about two to 3 weeks to finish the backlog of patient records. So in summary, and my view is this, there was medical care before computers came into medicine. There will be medical care when computers let you down. You need to have a degree of resilience in bolstering the IT defenses that we heard about this morning, but you also need a very practical what's to do right now when the system falls over. Where is your box of patient records? How will you access your blood results? What will your standalone radiology performance be? And how are you going to manage it if it becomes a prolonged incident? Thank you for your attention. Money, I have no idea. Mortality, I don't think there can ever be an accurate estimation. I suspect it wasn't very high. I genuinely mean that, because it was a short-lived episode. In that period, the trauma centre in that sector of London was closed for perhaps 24 hours. There would have been diversion of the major trauma patients to the trauma centres that remained open. I don't think in real terms, and I'm not qualified to give you an accurate figure, but my feeling is that there was not a significant, if any, increase in mortality. Morbidity, certainly. Definitely morbidity. We were resorting to first aid management of fractures rather than definitive reduction of fractures, as an example, and we were minimizing investigations, we were minimizing medical care that under normal circumstances we would take to a much higher level. So patients were getting suboptimal care for at least 24 hours, probably a bit longer, and their care was probably delayed for a while. But in terms of mortality, I think, my feeling is, and I can't give you any evidence, my feeling is it was not huge or not significant.